Good afternoon. My name is Kate McGrail. I'm a member of the Community Health and Wellness Division at Suburban Hospital. We are pleased to have you here today for our program, Lifestyle Factors Affecting the Risk of Alzheimer's Disease. Today's topic is participant-driven. Last May, we met today's featured speaker, Dr. Marilyn Albert, for the first time as she spoke about recent updates in Alzheimer's disease. We had nearly 100 participants that day, engaging meaningfully with Dr. Albert, with many asking specifically about lifestyle factors affecting Alzheimer's disease. So we're back today to take a deeper dive into this specific topic. We've had 170 registrations. Actually, it climbed since I wrote this, representing a very strong interest in learning more about the most common form of dementia affecting over 5 million Americans over the age of 65, as well as hundreds of thousands of individuals under 65 who have early onset Alzheimer's. Today, we're here to learn more about what lifestyle factors affect our risk of developing Alzheimer's disease, as well as current research supporting evidence in risk-reducing behaviors. We have expanded our allotted time today, leaving ample time for you to ask questions that will support your understanding of this disease, as well as personal wellness. Before we introduce our partner and speaker, I wanted to first cover some housekeeping items. We will be recording this session and we will share it with anyone who's registered. You may also access closed captioning at any time by clicking on the CC icon once. You will find that at the bottom of your screen on most devices. Because we are using Zoom webinar today, you will remain on mute. We highly encourage interaction with our speakers, so please use the Q&A feature to type a question. We will reserve time at the end of our program to respond to your questions. If you'd like to practice using the Q&A feature now, please go ahead and type the word yes if you joined the webinar with Dr. Albert in May, or you can practice by saying no if you weren't able to join us. And lastly, it's working. I see them coming in. Thank you. I hope you're able to engage with that feature. As a backup, you may use the chat feature, but I will be focusing on questions that start in the Q&A feature first. Lastly, the programming we offer is highly driven on your feedback, and we kindly ask that you take a moment at the end of today's session to complete a short evaluation. The form will pop up at the end of the session when you hit the red leave button. And if you're unable to complete that today, we'll follow up with an email when you receive your recording, and you'll get another copy of that evaluation to complete. All right, that concludes the housekeeping. A few quick words about the Village Ambassador Alliance. Did you know that the US Census Bureau predicts that by the year 2035, just creeping up on us, the number of adults greater than 65 will outnumber the children in our country? So with tremendous advancement in medicine, we are living longer, but we also want to live better, which is why I'll turn it over to Connie Rao to share more about the Village movement and how it is aligned with the goals of Suburban Hospital, that is to support older adults in healthy aging so that we can live, not just live, but thrive individually, independently, and empowered. So we're proud to have invested over $15,000 over the years to empower villages to make advances in aging at the neighborhood level, in addition to being able to offer seminars and learning opportunities such as these. So Connie, when you're ready, please feel free to.
Hi, and thanks so much, Kate, for inviting the villages to participate in this. Villages, I am the president of Friendship Heights Neighbors Network. For those of you who know the Washington area, we're in Friendship Heights. I am here also in partnership with Little Falls Village, which is an adjacent village. There are 30 villages in Montgomery County, another 10 or so in the district, and more in Northern Virginia, and some across the country. Villages are volunteer-led organizations mostly at the neighborhood or small area level, aimed at helping people who are 65 and older age in place. And that requires dealing with issues of loneliness, but also health and wellness. And we have all of us working together, been wonderfully helped by Suburban and in other areas, other hospitals, to bring important information about the things that go along with healthy aging as we go through the lifespan. I was telling Dr. Albert that in our particular village, we now have a great many members over the age of 80. Our latest join members are our average age of 89. So we certainly are now at the stage where we need information about how to prevent illness and how to deal with it, both from the standpoint of ourselves, but also for those many of us who are caregivers. So this information could not be more important. And again, I want to thank Kate so much for and Suburban Hospital for making it possible for villages to do this. And I'm looking forward, as I know you all are, to hearing Dr. Albert. Thank you.
Thanks so much, Connie. We appreciate that. And we, if you are a member of the villages, please reach out to me at any time to find out more ways where we can engage. And now I have the honor of introducing our featured speaker. Dr. Marilyn Albert is a professor of neurology at the Johns Hopkins University School of Medicine. She is the director of the Division of Cognitive Neuroscience and director of the Johns Hopkins Alzheimer's Disease Research Center. Over the course of her career, she has conducted several large longitudinal studies aimed at improving our understanding of Alzheimer's disease. The most recent of which is focused on the earliest phases of Alzheimer's. This work uses biomarkers based on imaging, cerebrospinal fluid, blood, and genetics to better understand the earliest phases of Alzheimer's, or AD. In addition, she has a long-standing interest in the study of lifestyle factors that influence the risk of cognitive decline as people get older. Dr. Albert has authored over 300 peer-reviewed publications. She has received many awards for her contributions to AD research, most recently the Henry Wisniewski Lifetime Achievement Award given by the Alzheimer's Association in 2019. With that, let's welcome Dr. Albert.
It's a great pleasure to be here today. I'm going to share my screen. Hold on one second here.
Yeah.
Okay, so.
Perfect.
All right, can you see that?
Yes, thank
Great.
you.
Okay. So it's a great pleasure to be here this afternoon to talk to you about lifestyle factors affecting the risk of Alzheimer's disease. I'm going to just say a very few words, a very brief introduction about the prevalence of dementia and how risks for cognitive decline fits into that. But I'm really going to spend the bulk of what I have to say this afternoon talking to you about the evidence we have for the impact of lifestyle factors as risk and protective factors for cognitive decline. You see here on the slide the topics that I'm going to cover: mental activity, physical activity, vascular risk factors, social engagement, diet, sleep, and hearing loss. But if there are other topics that I don't specifically address, I'd be happy to answer questions about them at the end. And then at the very end, I'll just say a few comments about the directions of the field, and I'll also include some sources of ongoing information where you can get continuous updates if you're particularly interested in this topic. So first of all, diseases that cause dementia. I think you all know that dementia is an umbrella term that refers to the decline in mental abilities until an individual is unable to maintain independent function. I have here on this slide the list of some of the major causes of dementia. Alzheimer's disease is at the top of the list, primarily because it's the one that's most common and it's the one that you hear about the most. So of all of those diseases that I had listed on the slide, Alzheimer's disease represents about 70% of all cases of dementia. And when we look at the brain of somebody who's died from dementia and has Alzheimer's disease, usually we also see other pathologies as well. We don't just see the pathology of Alzheimer's disease. You may know, and I'll allude to this later on, that the primary pathological markers of the disease are things we call plaques and tangles that are composed of a substance called amyloid and another substance called tau. And when people come to autopsy, we look for those plaques and tangles, but we also see lots of other diseases that occur at the same time. The most common is vascular disease, also something called Lewy body disease. The more we look at the brains of older people who have dementia, we're discovering actually other diseases that have strange names like part and late. But really the overwhelming problem in terms of dementia in the United States and worldwide is Alzheimer's disease. And we're increasingly concerned about it because the prevalence of the disease is related to age. And as was just alluded to, more and more people are living to older ages. So if we think about the major risk factors for dementia and cognitive decline, advancing age is actually the major one. So the prevalence of Alzheimer's disease increases quite dramatically with advancing age. If you look at a group of people who are 65 years old, the prevalence is about 5%. If you look at a group of people 85 years old, the prevalence is at least 30%, and some people would argue more. So the increase is really pretty dramatic as people get older. We also know that genetics plays a role in risk for Alzheimer's disease. There are some dominant genetic mutations, which are very, very rare. But if you have these mutations, you will get the disease. Usually, you know, if you have these mutations in your family, because people who get the disease tend to get it quite young. There are a number of risk factor genes that also increase the risk for Alzheimer's disease. The one that you have probably heard about the most is called the apolipoprotein gene, and the ApoE4 form of it is the form that increases risk for Alzheimer's disease. So of course, advancing age and genetics, we really can't do anything about that, or maybe advancing age, we don't want to do anything about that. But there are also lifestyle factors that are that can increase the risk for Alzheimer's disease. And of course, they're potentially modifiable. And that's why we're so interested in them. And that's, of course, why we're talking about that this afternoon. So I'm going to begin by talking about how the interest in lifestyle factors and cognition began, and then go over each of the major factors that I alluded to before and tell you what the most recent information is that we have about them. So in the late 1980s, the first study that was done, I think, that was looking at lifestyle factors that might preserve cognition if they were actively engaged with, was a study funded by the MacArthur Foundation Success Network on Successful Aging. And what they did was they put together a large longitudinal study that was community-based. There were 3 sites. All the participants in the study were 70 to 80 years old. And overall, there were over 1,000 people. So it was a very large study. And the goal of the study was to look at a range of factors among people who were doing well. to see whether or not you could identify those that predicted preservation of cognitive function, because the idea was that if they predicted preservation of cognitive function, that maybe these were modifiable risks that could reduce decline. In this particular study, people were followed for over 3 years. And subsequently, because of the influence of this study, there were many, many other studies around the world that did similar things. They were all community-based longitudinal studies. And what was interesting was that some of them actually included individuals who'd been followed since middle age. They had a very similar study design. They looked at a very wide range of factors among people who were doing well. They followed people over time, and the goal was to identify factors that predicted preservation of cognitive function. And just to give you a sense of the variables that people looked at in these kinds of studies, I have a couple of slides just briefly listing them. These are examples from the MacArthur study, but the other studies were quite similar. So there were demographic variables like age, gender, race, and income, lifestyle and health habits, education, physical activity, alcohol intake, smoking, chronic conditions like illnesses that people have, and also measures that might reflect that, like body mass index, physical function, including physical skill, and then various measures in blood like cholesterol levels and cortisol levels. And also a lot of psychosocial measures, looking at psychiatric symptoms, life satisfaction, emotional support, social ties, self-efficacy, and then some physiological outcomes. But of course, the major goal was cognition. And so in this study and in all the others, there were typically composite cognitive scores that were assessing how well people did across a range of mental abilities. So memory, language, executive function, attention, all put together in a single composite score. And I have here on this slide the range of large longitudinal studies that were conducted at that time. And I've selected some of them to particularly emphasize that not all of them were in the United States. So the ones that the first 3 were in the United States, but then there was the Canadian Study of Health and Aging, the Kungsholmen Project, which was in Sweden, the Berlin Aging Study in Germany, the Rotterdam Study in the Netherlands. And all of these studies ended up reflecting assessments of about 15,000 people. So this was really quite a lot of data. And once it started to accumulate over time, the National Institutes of Health decided that it would be good to get together a group of experts to review all these epidemiological studies and see if they could come up with consistent findings that were reflected in all of them. And this was called a Cognitive and Emotional Health Project. And the consensus review of all of these studies that I've been describing identified 4 predictors of maintenance of cognition, and I have them listed here. So mental activity, physical activity, vascular risks, and social engagement. And because these were epidemiological studies, all of this was self-report. So people said how much education they had, how often they read books, how often they went to community presentations, how often they walked up and down stairs, played sports, the vascular risk factors that they had, high blood pressure, high cholesterol, so forth. And then these self-reports about social engagement, such as social networks, feelings of loneliness, or having friends or family that you could rely on. And each of these measures separately were predictors of maintenance of cognitive function. But looking at the data overall, it appeared as if maybe these were additive. So if you had more mental activity, more physical activity, better control of vascular risks, more social engagement, that you would benefit more than if you had just one of these things. And this was, of course, above adjusting for age and for genetics in many of the studies. But I think you probably know that, that epidemiological studies have limitations. So we sometimes see that, associations are very strong, but then over time, when we look at things more carefully, we see that it's very hard to separate innate differences in people throughout their life that might be responsible for the results. And so, in the greater world, we really rely on randomized clinical trials to try to give us a sense of whether or not what we're seeing in observational studies really make a difference if you intervene. And so, you hear about randomized clinical trials and drug treatments, but these are just as important in studying lifestyle factors. And because everybody realized this, eventually, the National Academies of Medicine in the United States decided to gather a panel together to review all the intervention studies that were in this area. They published a book in 2017 called Preventing Cognitive Decline and Dementia, A Way Forward. And I was fortunate enough to be a member of this panel, so I can tell you a little bit about what transpired. So the idea was to review all the interventions with all these, lifestyle factors that had been suggested, not just the 4 that I mentioned, but any that anybody had come up with, and see whether the bulk of the evidence, see if the evidence really supported the value of these interventions. And this was a review that was commissioned by the National Institute on Aging. And what they decided to do was to have an evidence-based center at the University of Minnesota to review all the data. So the people who reviewed the data were actually separate from the committee members. Once they reviewed all the data, they gave it to the members of the committee, and then the committee reviewed it, and they came up with a report, which, as I said, was published in 2017. And at the end of the day, this report emphasized 3 interventions as promising: cognitive training, physical training, and management of high blood pressure. And what the report said was that there was, for cognitive training, there was moderate strength evidence. And that's actually quite a lot. High strength is the most you can come up with. And the committee thought there was moderate strength evidence for cognitive training. For physical activity, they said there was an indication of effectiveness, which is slightly lower than moderate strength. And for management of high blood pressure, they made quite a point of saying that they weren't basing this recommendation only on randomized clinical trials, but on the wealth of observational data that existed at that time. And I'll give you a little feel for that in a moment. But all in all, what they said was that these findings were promising, but they weren't sufficient evidence to warrant a public health campaign. So what I'm going to do now is review the information we have about cognitive training, physical activity, and management of high blood pressure, as well as other vascular risks, and then talk about others that the committee also didn't talk about. So first, cognitive training and maintenance of mental abilities. So the National Academies report made a big point of saying that there had been many observational studies and there had been a number of intervention trials. But the reason that they said that they thought the evidence was so strong was because of one particular trial, which is called the ACTIVE trial. That stands for Advanced Cognitive Training for Independent and Vital Elderly. And the ACTIVE trial took place between 1998 and 1999. As you can see here on the slide, there were almost 3,000 people in the study. All the participants were 65 and over. There were 6 sites involved. And the primary idea was to get together a group of people who did not have significant cognitive or functional impairment, to use 3 types of cognitive training, comparing it to a control, and to follow participants over time. And the data that I'm going to show you is based primarily on the 10-year follow-up. There was also a 5-year follow-up. And there are studies underway to look at the 20-year follow-up, which I'll allude to in a moment. But the basic idea was to determine if the cognitive training didn't just improve your memory or your executive ability on the tests that you were trained, but if it generalized to everyday activities, if it meant that in your daily life, you thought you were doing better over time. There were, as I said, 3 types of intervention. One was called memory, one was called reasoning, the other was called speed. And that was compared to a control condition where people were just sent educational materials. They really didn't see the participants in person at all. The big benefit of this study is not only the size of it, but also that the number of minority participants was quite significant. It was 25% of the total, which is really quite good. And the training was quite interesting. So there were 10 sessions over 6 weeks, and it was in-person training. And then subsequently, they had booster sessions, 4 of them at 11 and 35 months after this initial training in a random subset. And so the training really was not that lengthy. I mean, 10 sessions over 6 weeks is actually not that long. And people were trained in these tasks. They were given memory strategies to try to improve their memory. The speed task was actually what we call a dual attention task, where people were looking at, shifting amounts of information and trying to make a judgment about them. But one of the things that I think probably was important in this study was that they made an emphasis on trying to get people to think about how these tasks were related to their everyday life, so that when they would meet together, they would say, if you're switching your attention between one thing or another, this is sort of like driving. It might be related to your driving ability later on. They would do that for each of these cognitive domains involved in the training. And these are the results that impressed the committee from the national academies. This is 10 years later after the study. And what you can see is that for the first few years, I think you can probably see my cursor here. Is that right? These groups were very similar to one another. But then over time, at 5 years and then at 10 years, they began to diverge. And the people in the control group reported many more problems in what we call instrumental activities of daily living, how well they could just manage on a day-to-day basis, than the people in these training groups. The group that consistently did better on all of the analyses that have been done is the speed training, which I'm not sure anybody had anticipated, but the people in the memory group and the reasoning group also benefited. And that's despite the fact that all the training was here. It was at baseline with maybe a little bit of, booster session here at year 1. So this means that the benefit was quite long lasting. I should just say that the National Academies also addressed the question of brain training games, which you might have a question about. And it is true that these games improve performance on the specific tasks that are involved, but there are really no long-term follow-up studies related to these brain training games. And particularly, there's no evidence to date about a transfer of these games to daily activities, such as, we see in the active study. Hold on, something's happened here. Oh, good. So just to summarize what I've been saying about cognitive activity, it seems pretty clear that cognitive training can improve cognition on specific tasks, but the important question is whether or not these benefits transfer to broader daily activities. And this active study, which was so large and had a representative sample, demonstrated that cognitive training can have long-lasting benefits that transfer to everyday activities. And as I mentioned, There is research underway analyzing the 20-year follow-up, and it does look as if it's promising. I mean, we don't have the final results yet, but I'm hoping they will be available soon, so you can stay tuned. So now, what about physical activity and maintenance of mental abilities? I mentioned all the epidemiological data that was based on self-report years ago, and there have been continuing epidemiological studies of physical activity and risk for dementia. And one of the ones I wanted to highlight today was very recently published, and it was based on technology that we have available now that we didn't used to have years ago. So some of you may know that we can measure things like step counts or intensity of activity with something called an actigraph. And now you can do this in the context of a large epidemiological study. This is a picture of an actigraph that you wear on your wrist, or you could put around your waist, similar to smart watches that people might wear. And these devices tell you about the duration of physical activity, the intensity, and the patterns of physical activity. And what this recent study published in 2022 told us is that increased number of step counts is associated with a lower dementia risk. This was a very, very large study. There were 78,000 participants in it. And what they found was that if people had approximately 4,000 steps a day, it was associated with a 25% reduction in dementia risk. If they had 10,000 steps a day, it was associated with a 50% reduction in dementia risk, which is really quite substantial. Moreover, what they found was that it wasn't just step count that mattered, but also the intensity. So if people were walking with a moderate intensity of activity, it was associated with the lowest risk of dementia. So we still see, increasing amounts of data emphasizing from an epidemiological perspective an association between physical activity and risk of dementia. But what about the intervention studies? And these were the ones that the National Academies reviewed in particular. I'm just going to give you an example of one of them to give you an idea of what these studies are like. This is a study that was published in 2011. It was a randomized controlled trial. There were groups of people who did aerobic activity versus a group that just did stretching. The investigators looked at memory performance. They looked at structures of the measure of the brain based on magnetic resonance imaging. And they also collected blood to measure something called BDNF, which is a reflection of brain plasticity. There were 120 participants in the study. People were 55 to 80, and it was 1 year in duration. So it's not the 5 or 10 years of the active study, but it still was a reasonably good follow-up. And what they found was that specific regions of the brain changed over time in relation to aerobic activity. And in particular, one of the regions was the hippocampus. And you may know that the hippocampus is particularly necessary for memory, and that's why they were looking at it. And I'll show you, an image of what the data looked like in a moment. And even the change was very particular to the anterior part versus the posterior part of the hippocampus. So it was very specific. And memory performance was associated with this change in hippocampal volume, as was these BDNF measures. And this is an example of the data from this study. If you just look at the top panel, the line in blue are the people who were engaged in aerobic activity. The line in red is the people who were doing the stretching. And you can see that there was this increase in volume over time in the hippocampus. And they had various control regions. These are a couple of them, and you can see that that change didn't occur. So it appeared to be quite specific for this region of the brain, which is so essential for normal memory. There have been many other clinical trials like this. That's what the National Academies report reviewed, usually comparing aerobic activity versus stretching and toning. usually going on for 4 to 6 months, sometimes a year. And repeatedly, the exercise groups show improvements in cognition. And usually the aerobic activity is better than stretching and toning, but in fact, what they found is that the combination is better. And most of the studies actually show that the primary cognitive area that's improved is what we call executive function, or the ability to switch and plan and monitor your activity. And many of these studies also looked at brain structure and function. So that's why the national academies said that they thought that these were very supportive of the fact that physical activity makes a difference. The hypotheses we have as to how this might make a difference is that from animal studies, we know that this particular chemical that I mentioned, brain-derived neurotrophic factor, is actually produced more when animals are physically active. There's more what we call neurogenesis, which is the production of new nerve cells. And then, of course, being physically active increases blood flow to the brain, which might improve vascular health. So just to summarize what I've been saying about physical activity, we all know that it's beneficial for many aspects of health, right? Reducing blood pressure, reducing anxiety, improving sleep. The recent data suggests that moderate intensity physical activity is more beneficial than low intensity, but there's still a lot of research going on in this area, not only to look at the cellular and molecular mechanisms, the brain structure and function changes, the cognitive changes, but also how much physical activity, at what age can everybody benefit, and what intensity it needs to be. That's a lot of work going on, but clearly you can see from the data how important this appears to be. So now what about vascular risks and maintenance of cognitive function? The national academies emphasize blood pressure, and I'll explain that. I'll show you some of the data that they found supportive of that. But in point of fact, there are a number of vascular risks that people have looked at in epidemiological studies that appear to be related to declines in cognition. So high blood pressure, the presence of diabetes, high cholesterol, being overweight, smoking, and sometimes, many times in studies, people combine these all together to make a vascular risk score. So they look at, if you're higher on this vascular risk score, are you more likely to have cognitive decline, which in fact is the case. But some of the data that was most persuasive to the national academies was data that was just about to come out at that time. And this was from a study called the Atherosclerosis and Risk Study. And it had begun 25 years earlier when people were in midlife. And the goal of that study at the time was to look at vascular disease, look at heart disease, look at stroke, things of that sort. But over time, this study started looking at dementia. And what this study published in 2017 was that having hypertension in midlife was associated with a 39% increase in dementia risk over 25 years. So it was both what they called pre-hypertension as well as hypertension, or just being on medication in midlife conferred this much greater risk many years later. And the association with diabetes was even stronger. So having diabetes at midlife was associated with a 77% increase in dementia risk over 25 years. And I mentioned earlier this risk gene associated with Alzheimer's disease, the ApoE4 gene. And most studies come up showing that it really increases your risk for dementia quite a lot. And the statistics showed that diabetes appeared to have almost the same amount of increase in risk. So it's really quite a significant effect. At the time that the national academies met, this particular study had not been published, but it turned out to be very convincing. It was a study of blood pressure control. Like most of the studies of that sort, it was really focused on things like stroke. but they had added a cognitive assessment to it. And there were an enormous number of people in the study. It was over 9,000 people. They were 50 and older. They all had hypertension, and they were randomized to 2 levels of blood pressure control. One, the standard control, and one, a much more intensive control. And they actually stopped the study early because they could tell that the intensive control was so effective for the vascular risks that they were looking at, like stroke. But they also were able to look at the cognitive outcomes. And what they saw was that the risk of progressing to what we call mild cognitive impairment was significantly reduced by 19%. And that was statistically significant. The risk of dementia was decreased by 17%, which was not statistically significant. And most of the people who've looked at these data think that if they had been able to follow the cohort longer, they would have also seen a benefit on dementia. So this was a very impressive clinical trial controlling hypertension and showing how it had a significant impact on progression to mild cognitive impairment, which is the phase before dementia, and then possibly also an impact on dementia as well. We think that the potential mechanisms by which this happens, you're not surprised that it's because these vascular risks affect small and large artery disease in the vessels of the heart and also in the brain. But we also think that it might disrupt, these vascular risks might disrupt the blood-brain barrier. There might be increased inflammation or oxidative stress, all of which are not good for the brain. So just to summarize what I've been saying about vascular risks, it seems pretty clear that control of vascular risks is really beneficial in terms of things like stroke and other illnesses related to heart disease. There have been many observational studies showing the relationship between increased vascular risk and cognitive decline. And the findings from a randomized control trial have been mixed in general. Primarily, we think because they weren't all controlled trials in midlife versus late life, or they weren't done long enough. But that's why we think that the data from the SPRINT-MIND trial is so impressive, because it was conducted in both middle-aged and older individuals with aggressive control of blood pressure and showed these significant benefits for cognition. So now, what about diet and maintenance of mental abilities? Well, the National Academies didn't address diet, and I'm going to summarize the data really very quickly, because it seems pretty clear that different types of diets that you may have heard about are good for vascular disease, good for lowering blood pressure, lowering vascular risks. But at least based on the most recent randomized control trial, which was published just a few months ago, it doesn't seem to benefit cognition. So you've probably heard about the DASH diet, which is particularly good for lowering blood pressure, the Mediterranean diet, which also lowers vascular risks. The randomized control trial that I mentioned was called the MIND diet, which was a combination of the Mediterranean diet and the DASH diet. And they limited the intake of high saturated fats. They had increased intake of berries and green leafy vegetables. The data were not significant. So this was a publication in 2023 suggesting that this diet versus a control diet didn't have a benefit in cognition. So I think we can conclude from this that the dietary changes primarily appear to benefit vascular disease, which of course is important because vascular disease can contribute to cognitive decline, but it's just that it doesn't appear to directly benefit cognition. I mentioned social engagement in the beginning, and again, I'm going to be pretty brief in summarizing the results of this. So the epidemiological studies have looked at things like how feelings of self-worth, feelings of self-efficacy, mood, anxiety, loneliness, the degree to which, what your social networks are, how many people you're engaged with and you feel you can rely on. And these were the kinds of measures that appeared to be predictive of maintenance of cognitive ability. The hypothesis was that maybe this was important because if you feel more out of control of things, you feel you don't have people you can rely on, the stress hormones are increased and these affect the brain. But also that if you feel lonely and you feel not connected to other people, you might be less compliant with healthy lifestyles. So far, it's been very difficult to look at this in anything other than an epidemiological study. There is a study that you may have heard about that was conducted in Baltimore from Johns Hopkins called the Experience Corps, where they took a group of older people and they put them in the public health, in the public school system. They taught them how to mentor the young people. They measured things like social engagement as well as cognition, but all of these things were combined together. And so it's been very difficult in a controlled randomized trial to look at social engagement in and of itself. And so we really don't have much more information about this than we did years ago. So now I want to talk about a couple of areas that weren't addressed in the National Academy's report. I think primarily because the data at that time were not so convincing, and some of the data I'm going to show you are really quite not having to do with sleep, but other areas are very, very recent. So first I'm going to talk about sleep. And the epidemiological data suggests that duration of sleep, disruption of sleep, changes in the sleep-wake cycle, physiological problems related to sleep like breathing, are increased risk for cognitive decline. In the context of looking at all the potential causes of sleep changes, you have to take into account that it's not just changes in the brain. As I said, it can be changes in breathing or changes in heart rate. So from the perspective that we're talking about, we're interested in how much it's changes in the brain that are really related. It seems pretty clear that the aspects of sleep related to cognitive decline are not just that sleep is too short, but also that it can be too long or too disrupted, also, of course, of poor quality. And in the context of an epidemiological study, a lot of people look at this by having people answer standard questionnaires to talk about their sleep quality, duration, and disturbance. But here again, this actigraph that I mentioned earlier comes into play, because those devices that you wear on your wrist can also tell you something about sleep. So total sleep time, wake after sleep onset, sleep efficiency. So you can get very sophisticated measures about sleep, even in the context of an epidemiological study, but certainly in more detailed studies. What's particularly interesting about sleep is not only that we see that it's very much related to changes in dementia. You see here the problems with total sleep time are very clearly related to the presence of dementia as opposed to people who are less cognitively impaired. But what's unusual in sleep when it comes to these lifestyle factors is that it's the one area that people have argued may directly affect the pathology of Alzheimer's disease in the brain. And as I mentioned earlier, we know that the plaques that are seen in the brain in Alzheimer's disease contain amyloid, the tangles contain tau, and we can now measure amyloid and tau in the brain. And this is just data from a recent study from 2022 showing that sleep quality, sleep duration, sleep disturbance all seem to be related to changes in these Alzheimer's disease biomarkers. So this is saying that possibly this is really quite directly related to Alzheimer's disease in particular. So we don't really have any question that poor sleep is related to changes in cognition and increased risk for dementia. But what's interesting, as I said, is this association with AD biomarkers. What we, I think, are not totally clear about yet is whether or not the changes in sleep patterns cause the changes in Alzheimer pathology, or whether the accumulation of Alzheimer pathology alters sleep. And there is a good deal of evidence to suggest that it might be a bidirectional relationship, that both of these things might be going on. And so this is a very big area of research that's underway right now. I also wanted to say something about hearing. This is something, again, that the National Academies didn't talk about, but there's very recent data that I knew you would be interested in hearing about. So there's a good deal of evidence from recent epidemiological studies that hearing loss is associated with a greater risk of cognitive decline and dementia. And in fact, a study published in 2023 that was what we call a meta-analysis that looked over a lot of observational data, suggested that if you used hearing aids, there might be a 19% reduction in cognitive decline. And the data that I'm going to show you that were really just recently published is the one randomized control trial in this area. I don't think there's been any other, and I'm not at all sure that there'll be another one. It's called the ACHIEVE study. And the goal was to see if giving people with moderate to severe hearing loss hearing aids altered cognitive decline. But they were also interested in whether or not it had an impact on social isolation and on loneliness. There were a total of 977 participants in the study, 70 to 84 years old. And all the participants were thought to be relatively cognitively intact and had untreated hearing loss. And these are slides that I got directly from the person who led this study, who's Frank Lin, who's here at Johns Hopkins. And the question, as I said, was whether or not treating hearing loss could reduce cognitive decline over 3 years in adults with hearing loss without substantial cognitive impairment. There were, as I said, 977 participants. The people who had the hearing intervention they were given hearing aids for free. They had counseling in how to use them. There was this successful aging education control where people talked about control of various disabilities and chronic diseases, and the people in the control group were told that at the end of the study, they would get a hearing aid. And as I said, the outcomes were cognitive decline, but also brain structure, physical activity, healthcare use, and so on and so forth. And this slide summarizes the results. What this group found was that among a subset of the participants, there was a 48% reduction in cognitive decline. Now, I had originally a whole lot of slides talking about this subset, and I decided to simplify things. But at the end of the day, what they found was that the sources of participants in this study came from two places. One was the study I mentioned earlier, the atherosclerosis and risk and community study. And these people had more risks. They were older, they had slightly less good health, they had lower levels of education. And this group of participants were the ones that showed the 48% reduction in cognitive decline. The people who were newly recruited from the community did not show this benefit. And so what's happening, of course, now is that there's longer-term follow-up of this cohort. So the potential mechanisms by which treating hearing loss might be beneficial is hypothesized to be three. One is this idea of cognitive load, that if you're trying really hard to listen to people, the cortical resources, the cognitive load that you're using might not be used to sort of combat other pathological changes that are occurring in the brain. There's also this hypothesis about sensory deprivation, which suggests that if you have hearing loss, you actually have more brain atrophy, and you're adding that brain atrophy to the atrophy related to Alzheimer's disease. And then this question of social isolation and loneliness, because people who feel more isolated, can't interact because of hearing impairment, maybe are less physically active, less involved in cognitively stimulating activities, maybe they have more stress hormones, maybe they're less adherent to medical care. So just to summarize, the ACHIEVE study showed that a clinical trial that gave people hearing aids could really lower the risk for cognitive benefits, but a longer term follow-up is really needed in order to look at this other group that had fewer risk factors and to see if there are other outcomes that benefited, such as brain atrophy, health-related quality of life, and healthcare costs. So this is something that you really need to watch over the coming years. And lastly, I just wanted to say a couple of words about combinations of lifestyle interventions. So I said earlier that the evidence suggested that if you combine these risk factors, if you combine these interventions, you might benefit more than one of them by itself. And the major study that looked at this is a study called the FINGER study. Stands for Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability, obviously was conducted in Finland. It was a 2-year randomized trial, and they did cognitive training. They had people increase exercise. They monitored vascular risk and diet, and that was compared to a control group. It was a pretty large study. There were over 1,200 participants, 60 to 77, and they showed significant findings on an overall composite score as well as some domain scores. So I show here the data from this overall composite. You can see that there's a separation in these lines between the people in the intervention and the people in the control group. That was also true for the executive function measure. The processing speed was not true for the memory measure. And interestingly, the processing speed benefit was very similar to what I described earlier in the active study. Another thing that they showed was that adherence really was very much related to the benefit that people had. So if they were less likely to adhere to all of these different interventions, which of course took a lot of time and commitment, then they were less likely to benefit cognitively. So just to summarize, this multi-domain intervention had a significant benefit. Based on the statistical findings, the benefit is modest. But it's very interesting that those who were adherent to the benefit to the intervention showed the largest benefit. And of course, we know that behavior change is challenging, and this is just one aspect of things that we need to take into account in the future. We don't know exactly all the factors that influence adherence, maybe depressive symptoms, maybe attitudes toward the intervention. But this whole idea of behavior change is one that people are looking at now very closely, particularly when it comes to any of these interventions. Because of the impressive data from the FINGER study, there are now several multimodal clinical trials in the field. The one in the US is called the US Pointer Study. There's also a worldwide FINGERS network, so you'll be hearing much more about this in the future. So just to conclude, it seems that pretty clear that multiple factors predict maintenance of cognitive function in older persons. The statistical evidence suggests that a combination of the factors are more effective than one factor alone, although that's just suggestive. But there's a lot of more work to be done to know exactly how much intervention, at what age, and particularly how to get people to modify their behavior to go along with these suggested changes in lifestyle. There is, as reflected by the attendance at this seminar, a really exploding interest in this area. The Lancet Commission has been now issuing reports approximately every 3 years. That it's not a systematic study such as the one done by the National Academies, but it's the consensus of experts about what risks seem to be, lifestyle risks are important for reducing risk for dementia. And I would particularly mention the Global Council on Brain Health of the AARP, which has a website, which I have here, which has a lot of information already on the website telling you about these various lifestyle factors, but continues to add to it over time, and all kinds of really valuable information available there. If you wanted to get the National Academies report, you could get it here as well. So lots more to come, but I'm delighted to talk to you this afternoon, and I'm happy to answer any questions that people might have.
Thank you, Dr. Albert. That was fantastic, so thorough. I love the timeline of where we started and where we are now. I invite everyone to start adding your questions to the Q&A feature down at the bottom of your screen. I'll start with the ones I have that came in earlier, starting with, what is a recent blood test for Alzheimer's disease?
Oh dear. So I mentioned the plaques and tangles that are the pathological hallmarks of Alzheimer's disease. And I mentioned the amyloid and tau. And we know that we can measure amyloid and tau in cerebrospinal fluid. And we know we can measure it with positron emission tomography. These are called PET scans. And we've been measuring in cerebrospinal fluid for many, many, many years. The PET scans are more recent, particularly the tau PET scans. But within the last couple of years, that people have developed blood tests that reflect how much amyloid and tau, and particularly what we call phosphorylated tau, are in the brain. My own group here at Johns Hopkins has data on this. There's a number of people across the world who have published findings on this. These blood tests are very encouraging. I think we still don't know exactly which ones are best, and we also don't know what bodily changes might affect them. So, for example, there's recent evidence to suggest that if you have abnormal kidney function, that it might alter these tests. There's recent evidence to suggest that if you really want a good result, you need to collect the blood fasting as opposed to after you've had a meal. So these blood tests exist. We're in the process of learning about how well they can predict likelihood of dementia. I'm sure that within a few years, they will be available to everybody. And then we'll have to be really careful about how we use the information that we get.
Great, thank you. To the folks who have raised their hand, we'll ask you to please type your question in the Q&A box. The next one for you, Dr. Albert, is the MacArthur Foundation study is so important. What was the genetic makeup of the subjects?
Actually, we don't know the genetic makeup of the subjects. This was in the late 1980s, and we didn't study it. I wish we had. But it was really a representative sample. It was a community sample. There were 3 sites, and the one that I was involved with, which was in Boston, we went door to door in a working class neighborhood. So this was a very representative population. So we don't know the genetic makeup, but we do know that it was very representative sample. I wish we did.
How helpful is movement if you are at a higher risk of dementia, especially if you have family history?
What was the beginning of that question? How helpful is
movement?
Movement. Well, I mean, I think that what I was saying about physical activity indicates that it's very important. And I think it's important for people not to feel like the goal of physical activity has to be too high. So, the study that I mentioned about the number of steps you take making a difference. So just walking seems to be beneficial. Walking with more intensity is beneficial, but if you're just walking, that's good. What I say to people is to find something that you love to do and do it. So maybe people, I don't know, like pickleball. Maybe they like to work out on a piece of equipment in their home. Maybe they walk more often when they walk with a friend. So you need to find something that you'll be able to maintain, because I think that's the big challenge for all of these lifestyle interventions, is maintaining them over time and finding a way that will allow you to continue to do them without making it feel like it's a big task.
Does physical activity increase the number of brain cells?
So we think that in animals it does. So what happened actually is that when the MacArthur study was published, there were a number of people in that network who were basic scientists. And so they went back to their labs and they did all these studies with animals, mostly with mice and with rats. And it seems pretty clear that the mice and the rats, if they were more physically active, if they were in an environment that had lots of things for them to crawl around and jump on that they enjoyed, had more of this, what I mentioned, brain-derived neurotrophic factor that creates plasticity in the brain, but it also increased the production of nerve cells. And the new nerve cells are actually only produced in two regions in the brain. One is the olfactory bulb, which is having to do with smell, but the other is the hippocampus, which is the brain region I mentioned that has to do with memory. And so we hypothesize that some of the benefit of physical activity might be neurogenesis in the hippocampus. We know that that occurs less as people get older, but it does occur. And so that certainly might be one of the mechanisms by which physical activity is beneficial.
Is there value, or what is the value of MRI in predicting and following Alzheimer's disease?
Okay, that's a good question. So MRI tells you about the structure of the brain. So it can't see these plaques and tangles directly, but it can see the brain damage that occurs from them. So if you have a lot of plaques and tangles, ultimately nerve cells die. And when they die, then you have more shrinkage in the part of the brain where those nerve cells are dying. And so what people have focused on over the years is using MRI to measure regions like the hippocampus, which is where we know this pathology begins. And it's also why patients with Alzheimer's disease have trouble with their memory, because the hippocampus and the entorhinal cortex are both essential for memory, and for reasons we do not know, that's where particularly the tangles begin to develop. So you can use an MRI scan to measure the volume of these regions. And many, many investigators around the country have been doing this for a very long time. And we know that you can look at the volume of these regions, and they're associated with a likelihood of progression from being normal to having mild cognitive impairment, or from having mild cognitive impairment to dementia. And so they're very good for tracking the evolution of the disease over time. I should mention that you all probably know that there's a drug that has been approved for Alzheimer's disease called lecanemab, or Leqembi. And MRI is actually required for people who are taking that drug, but it's to look for side effects from the drug, not so much to look at the progression of the disease.
Is a PET scan used in the diagnosis?
So PET scans can be used in the diagnosis. We've had amyloid PET to look at this substance of amyloid that's associated with the plaques. since about, well, I think the first scans were shown in 2005. So it's been around a long time. We've used it in our research for a very long time. Now there are amyloid tracers that are made by companies, and there are standards by which you can have a nuclear medicine physician read an amyloid scan and say whether or not there's too much amyloid or not. So one of the things that's more puzzling, I would say, in Alzheimer's disease and surprising is that when amyloid begins to develop, it seems to develop everywhere, not just in very tiny regions. And so that's why when the scans are read, it's just, is it positive or negative? Is there a lot of amyloid there or not? And sometimes when people come in to have an evaluation, they will have a PET scan and somebody can read it. The reason that those PET scans are not used that often is because they're enormously expensive. So it costs, I think, on the order of $6,000 for a single PET scan. For this drug that I was mentioning that's been approved for treating Alzheimer's disease, you actually have to be amyloid positive in order to receive it. And I think for those people, then Medicare reduces the cost. But in general, most people have to bear the cost. And so that's why it's not used that often. You can also look at cerebrospinal fluid the same way. You can say, does somebody have too much amyloid in their brain or not, as part of the diagnosis.
Okay. What is the recommended time for REM, core, and deep sleep?
Oh, I think that varies. So REM sleep is the deepest form of sleep. It varies really with the individual. I think that most of the studies have shown that it's the interrupted sleep, and because it's interrupted, it might interrupt REM sleep, but it's also sleeping too long or sleeping too short. So, and the recommended amount varies. I mean, sometimes people say overall you ought to sleep 6 or 7 hours, but I don't think anyone has a very firm fix on what's optimal, particularly among older people.
This one is about if you use a sleep aid such as Valium or a CBD edible, does that count towards getting a good night's sleep?
Well, first of all, something like Valium is kind of discouraged in older people. It has a very long half-life. If you're using it for sleep, I mean, there are drugs like trazodone that are much safer for sleep. And if, for example, well, right now at Johns Hopkins, there's a clinical trial looking at trazodone in people with sleep complaints and trying to see how that benefits cognition as well as other aspects of brain function. So if you're getting good sleep for a drug like trazodone, that counts. That's good. So nobody thinks you have to have it without a drug. It's just that you need to be really careful what drug you're using because some of them have negative side effects.
How do medications affect cognition?
Well, of course, it varies with the medications that you're talking about. So if you're taking medicines that are controlling vascular risks, that's really good. We would encourage that, and we would encourage optimal control of vascular risks. I didn't say this earlier, but what we believe is happening in the brain, as best we can tell, is that it's the amount of Alzheimer pathology you have is sort of additive to the amount of vascular pathology that you have. And so if you have both of those things, you're more likely to have cognitive decline. So those medications you absolutely want to take. But there are medications, as I was alluding to, that don't have good effects. A lot of the pain medications can make people more confused. I was just mentioning Valium, but there are lots of others that stay around. You know, they have a very long half-life and they can reduce cognitive decline. So when we evaluate people in the clinic, one of the things we always ask are what medicines people are taking. And if they're taking very strong medications like Percodan, for example, for pain, then we try to see if they can reduce it, because things like that can influence, cause cognitive decline.
All right. Have there been Black women included in any of these studies, and specifically the MacArthur study?
So the MacArthur study was a population study, and I think maybe the percentage of people who were African American was low. I want to guess that it was 10%. I don't actually know. But one of the things that was so important and valuable about the active study that I mentioned is that 25% of the population was minorities. And more, really, it's very hard to get a study funded by the NIH if you don't make every effort you can to include minorities. This certainly wasn't true years ago, but it is true now. And increasingly, that's what people look at. So, for example, this drug that I mentioned that's been approved for Alzheimer's disease, Leqembi, one of the concerns that people have about it is that the number of minorities in the study population was very low. And so it makes it hard to generalize the results to people, across the US population, above and beyond the ones who were just in the study itself.
Does technology, including your phones for reading, help or hurt our cognitive function?
I don't know that anybody studied that, but I would guess that it helps. I think it means that we're more likely to be multitasking, doing multiple things at the same time, switching back and forth. I think it means we're more in communication with other people, which alleviates things like, feelings of loneliness, and more likely to be able to get information that's mentally stimulating.
Like today.
Like today, exactly, like today. So yes, I think it probably helps, but I don't know that we have any data on it.
Is there this is my question, a caveat with like the blue light before bed interrupting your sleep?
I don't know. I mean, I tend to actually turn my phone over, so there's no light bothering me during the night.
Oh, right. I think they've said to like disengage from your screens about an hour before rest to kind of let your brain settle into.
So everybody, when you talk to people about sleep, you talk about sleep etiquette. So it's not only not looking at your phone, it's not looking at something on the news that might upset you. It's not eating certain foods that might keep you up. It's a whole range of things that you need to think about if you want to improve your sleep.
So we have another kind of follow-up question about the proportion of REM, deep and core sleep matter.
So I think that we don't have hard recommendations for that. I'm not a sleep expert, and so I shouldn't pretend to say that I am, but to my knowledge, nobody has said that there's a set proportion of REM sleep that you're supposed to have in order to sleep more efficiently.
Mm-hmm. Are there reports that demonstrated that handwriting may prevent cognitive decline?
I think maybe that question comes from the fact that there was a study many years ago called the Nun study, and people studied the documents that the nuns had written when they were very young and showed a relationship with risk for cognitive decline. But I think in retrospect, most people think it had to do with things like level of education and, in general, fund of knowledge. And we know that more education actually reduces risk for Alzheimer's disease. We think that it's not just that people had the education when they're young. We think it's because that means they're much more likely to be mentally active over the course of their life. but not handwriting per se. I don't know of anything particular about that.
If you have a genetic predisposition for Alzheimer's disease, would these other interventions be helpful in cognitive decline?
That's a really good question. So there's a lot of research going on now about whether or not people who are ApoE4 benefit from these kinds of interventions. In particular, people have been looking at it with respect to physical activity. I don't think in the active study that they looked at people's genotypes and I know that they didn't in the hearing study either. But the impression that I have so far from the data is that people who are at more genetic risk because of this ApoE4 allele also benefit from these interventions and possibly benefit more, but I think more research is needed, but it's certainly going on.
The next one shares gratitude for your presentation and then asks, is the brochure that you mentioned at the end available on alzresearch.org?
So this brochure, is that the one you mean? This is from the National Academies that you have to get from the National Academies. And I have here on the website where you can download it. It's not a very long document, and I would encourage you to look there. On alz.org, alzresearch.org, that's the website of our Alzheimer's Center, and we have links to a lot of these sources of information. So you could also go there, but you could go directly to, in this case, the National Academy's website.
Are there any medications increasing brain blood flow or, here's a big word, maybe that's two words, other physiologic measures that show promise of reducing dementia risk?
So no medications that I know of yet. No, there aren't. But again, we're going back to vascular risks. Anything that you can do to really treat vascular risk, to treat high blood pressure, treat diabetes, not be overweight, not smoke, not drink to excess, lower your, those are all going to be beneficial. And, right now, and those will improve blood flow to the brain because they'll reduce the vascular disease in the vessels.
Speaking of excessive drinking, a question that came through email was, what constitutes that phrase for excessive drinking?
Well, I think the data suggests that maybe one drink a night is okay and is actually maybe beneficial, partly because it might reduce stress, and that's good. Also might benefit vascular disease. But more than that per day is not good. And of course, excessive drinking is really bad. I mean, there's a direct effect on the brain from excess alcohol. And then people who are taking too much alcohol might have injuries, might fall and hit their head, which also obviously is not good.
When high blood pressure is talked about as a risk, is there any difference between those on blood pressure medication and those not?
Well, yes. I mean, what the National Academies emphasized was that if people have high blood pressure, it's really important for them to treat it and really important for them to take medicines. And the Sprint Mind study that I mentioned shows that it's actually very important to treat high blood pressure aggressively, not just the standard methods if you're, if blood pressure is a concern. So anybody that has high blood pressure should absolutely have it treated. And I mean, it's not a big deal to take your blood pressure every day, even if you're taking medicine and tracking it. You can take it, you can see if it's too high. I mean, sometimes blood pressures go up and down, and so you don't want to be changing medicines all the time. You want to see the general trend, But if you're tracking your blood pressure and you think the blood pressure medicine you're taking is not controlling it well enough, then it's very important to contact your physician and have it changed.
Which
I mean,
individual?
the way I feel about treating vascular risks is that this is one of the things we know a lot about. We have a lot of medicines for this. And so we can't emphasize too much how important it is to control these vascular risks.
Which individual lifestyle factor do you think holds the greatest promise for delaying Alzheimer's disease? I'm sure everyone was thinking this, including me.
I don't know that we know, right? I mean, we've not compared it. And maybe in these multi-domain trials, maybe they will find out, that if people were more involved in the cognitive training, but less adherence to the physical training, we might find out which are more beneficial. I just urge everybody to try and do what they can, but to find a way to maintain it. And the only way you can maintain it is to find a way to do these things that you like. So if you like to go to seminars like the one we have today, then go to them. If you prefer crossword puzzles, then do that. If you, just like to walk, you don't like to do, intense physical activity, that's fine. Just find things that you do consistently. I think that they'll make a difference.
Actually, the next question is going to kind of pare that one down. If you have a compromised immune system, what types of activities or actions can you take to protect your intellectual and emotional health?
Well, fortunately, with social media and all this virtual communication, there are lots of ways to be cognitively stimulated without being with other people, right? So you can watch programs, you can communicate with family and friends virtually. You can walk either by yourself or outside with friends where you don't have close communication. So I think there are lots of opportunities for people who have, impaired immune system for enacting all of these different interventions.
Does a diagnosis of mild cognitive impairment necessarily lead to Alzheimer's?
That's a good question. We know that a diagnosis of mild cognitive impairment means you're at much greater risk of progressing to dementia. But it's important to know what the cause of the mild cognitive impairment is. So when in our research, and in general, what a physician will do is say, what is the syndrome does this person have? Do they have dementia? Do they have mild cognitive impairment? Are they normal? Once you decide on the syndrome, then you decide on the cause. And people can have mild cognitive impairment primarily because they have a lot of vascular disease. They've had small strokes, they've had, coronary artery bypass grafting, they have atrial fibrillation, they have a whole bunch of vascular risks. And when you see those in great, quantity, then you say, well, maybe this is the cause of the cognitive impairment. In those individuals, if you're treating those illnesses aggressively, then you might be less likely to develop dementia. But if it's because you have mild cognitive impairment and you have Alzheimer's disease as the underlying pathology, right now, there aren't a lot of ways of treating it. I mean, we have this one medicine that shows some modest benefit, but that's why we're spending so much time looking for other ways of treating things. And it's why these lifestyle factors are also important, because everything that you can do to maintain yourself at a point where even if you have cognitive changes, you're able to manage independently, which is what mild cognitive impairment means, the better that is.
All right. Just a quick note, thank you for all of your fascinating, very good questions. We'll have about time for one, maybe two, before we have to let Dr. Albert go. So what is the relationship between sleep apnea and dementia? And have there been studies about the use of CPAP machines to reduce dementia?
Yes, that's a good question. So, whenever anybody has sleep apnea, we urge them to treat it aggressively and consistently with a CPAP machine or with anything else that their physician recommends, because it does increase cognitive decline. And that's why I was saying that the study about, the studies of sleep are complicated by the fact that many things can disrupt sleep, one of them being sleep apnea. Whenever we see that somebody has problems with sleep apnea, we always encourage them to have it treated. If there's a question about it, we encourage them to have a sleep study to know whether or not they have it, because that's, again, one of the things that you can control that can make a difference in the likelihood of cognitive decline.
Thank you, Dr. Albert. We are exactly at 3:30. And so I appreciate this interactive opportunity, despite no faces and all mute. It was fantastic. Thank you everyone for joining. We did hit over 100 folks joining us today. We look forward to learning a little bit more about where you're from as you complete your anonymous evaluation at the end. If you joined us from a village or how you heard about this opportunity, please let us know and be very open with your responses, because we do make changes and improvements based on your feedback. Thank you for staying engaged. And Dr. Albert, we hope to find you hopefully back here again in the year as these updates are continuous and we're learning more about how to stay healthy and well cognitively. So thank you so much for your time this afternoon.
Great pleasure to talk to all of you.
Absolutely. All right. Take care, everyone. Go
Bye-bye.
for a walk. It's beautiful outside
That's
today.
right. Talk to a friend.
Right. Call your friend and go for a walk. Perfect combination.
Listen to an audiobook at the same time.
And then do your crossword puzzle. Okay. We got plenty of keep you busy. All right. Be well, everyone.
Bye-bye.